Hi everybody, we're back again with our 2-hour live feed today, and I'm very excited because this is going to be a live feed on endometriosis and how we treat it, diagnose it, and deal with the problem as it pertains to fertility. I did one talk on endometriosis a few weeks back and the response was enormous. We had 10,000 plus people attend, and there was such an interest in it that I got many people emailing and texting us, telling us they want us to do it again and expand on it. So I've decided to do another one today. The topic is endometriosis. I'm Sher. I'm an IVF doctor. I've been doing in vitro fertilization for almost 40 years. I introduced the first private in vitro program in America, and I've been influential in the births of over 17,000 IVF babies. I've also contributed proudly to a number of the breakthroughs in the field of IVF, some of which you may or may not hear about today. Endometriosis is our topic, and this is where we're going to be focusing. For those of you that are joining us right at the beginning, I'm going to be talking a little later on again, spending more time on the introduction to the field of endometriosis and infertility. Take 5 or 10 minutes, so please hang around. Make sure you watch that. It's going to be very important, because endometriosis is a very, very common problem in any infertility clinic, where 25 to something like 30% or maybe even more of people that attend the clinic either have endometriosis as the primary cause of their problem or have it as an associated problem which is also influencing success and failure. And my job here is to inspire and educate. That's all, to inspire and educate. It's not my job to tell you what to do. That's your decision. And so I'm going to give you the information which I hope will help you make that choice. So we're going to start with a few questions, and as soon as we've got more people in attendance, I'm going to come back and talk a little bit about, as an introduction to this whole topic, endometriosis. But because it's on endometriosis doesn't mean I won't answer questions on any other aspect of infertility and IVF related issues. I will, but I'm going to try to make my focus on endometriosis.
Perfect. If you're just now joining us, Dr. Sher will be answering all questions on endometriosis and IVF. Go ahead and drop any comments or questions that you have for him, and he'll answer them live right now. We're going to answer our first person of the day so far is Mandel. They said, is there an actual cure for endometriosis, not just getting pregnant or a partial cure?
Alas, there is no cure for endometriosis. It's a condition that you're destined to get because of a probable genetic predisposition and something that occurs in more commonly Caucasians and people of the reproductive lifespan. But you get the condition, and I'll be talking about it in a short while in some detail. You get the condition in the beginning. It's not even visible or detectable, but later it does become detectable, but it's a master of disguise. And so endometriosis is something you've got for life. I call it the gift that keeps on giving, only it's not a good gift that you receive, because it impacts on your ability to achieve a viable pregnancy. And in the early stages, you may not have any symptoms, and all the tests that you do can be negative. But you're developing, or in the process of developing, this problem. And when you get to the doctor, they test you and they can't find a reason for your infertility. They even do a look-see procedure called laparoscopy, where they put a telescope-like instrument through your belly and look in the abdomen. They can't see anything. And so they label you as unexplained infertility. What that usually means, it just wasn't diagnosed. You come back a couple of years later to be retested, and then when they do a repeat laparoscopy, they find the endometriosis. You didn't just develop it, you had it all along. And the problems that were coming up were developing along the line from that time on. And we're going to be talking about this a little bit more as I proceed to my discussion with you in a few minutes.
Okay, Liza said, what is the difference between adenomyosis and endometriosis? Are they the same or are they similar?
That's a very good question. They're completely different conditions. Originally, adenomyosis used to be called internal endometriosis, and endometriosis itself external, because it's external or outside the uterus, whereas adenomyosis is where the glandular tissue that you menstruate from every month and where the baby attaches to, called the endometrium, sends its roots into the wall of the uterus. And in the process of doing that, you get the roots of the endometrium spreading into the muscle itself. And in the process, it can compromise blood supply into the uterus, make the lining thin. Treatment is completely different. But adenomyosis is commonly associated with women who've had a lot of babies. And endometriosis is more commonly in people that have had difficulty getting pregnant. The reason adenomyosis will need treatment in some cases is because by growing into the wall of the uterus, it can compromise the blood flow to the uterine lining, and so the uterine lining can develop thick enough to allow the roots of the embryo to attach properly. So when you get adenomyosis, and the best way to diagnose it is by MRI of the pelvis. You can't easily diagnose this by ultrasound. So when you see it and you know it's there, the time you need to treat it is if there's a thin lining of under 8 millimeters at the time of ovulation. If there is, you need to treat it to increase the thickness of the lining. And you do that using something called vaginal Viagra compounded suppositories in the cycle, and you do that in combination with estrogen administration. So we'll talk more about that if the opportunity arises later, but it's a completely different condition.
Cool. All right, we're going to thank our first gift of the day from Wellness, or Well Necessary. Thank you for the rose. We appreciate it. Our first rose of the day. I'm going to answer Bree here on TikTok. She says, what transfer protocol would you do for your patients with endo?
Transfer protocol that we'd use is no different to the usual transfer protocol. But the preparation for the transfer may differ completely depending upon when or whether there's an underlying immunologic problem, which occurs in 1/3 of women with endometriosis, no matter how mild, even before you even can see it visibly. So it all depends whether you do certain preparations for endometriosis, for the embryo transfer. But it is no different in technique than for any other embryo transfer you do. Now, while I got you, just a little introduction to those of you that are there. Please go to my bio. I'm going to say this over and over because I think it's helpful to you. Go to the bio and click on the link, which will give you 3 choices that you'll see. Option number 1 will be to get free downloadable ebooks that I've written, along with 2 articles I've just completed, which I think are very, very important for you to read. You will get them by return email as downloadable emails, free of charge. Please do that. There's not a single reason not to. They're going to educate and inspire you. I took a lot of time writing these articles, and I wrote them with my New York partners at Sher Fertility Solutions, Dr. Drew Tortoriello and Dr. Ravi Kumar, Dr. Sitara Ravi Kumar, who work with me in our office in Manhattan. You're going to get these 2 articles that are very important. The one is on an overview of endometriosis, what it's about, how we treat it, why we treat it in a certain way, and what the success rates can be if you do it correctly. And they demystify some of the things that are often introduced by doctors in the treatment which don't help. Read those 2 articles and get the 2 books. The one book is 300 plus pages long. It's an operational manual which talks all about all the issues in IVF, how we diagnose them, how we address them, how we treat them. This book will be coming out in the bookstores, but at the moment it comes to you in a downloadable ebook. Now these are the books, the 2 books that I have. And the other book is a thin book on the immunology and the way in which immunologic problems impact success in IVF or can result in failed IVF with good quality embryos or repeated miscarriages. I'm one of the pioneers of this field, and this book is very, very helpful. It's only 50 pages long. It also comes to you free as a downloadable ebook. Please get it, every one of you, and hand it around. Send it out to your friends that have got similar problems. The second option you get is if you want to have an opportunity to engage and talk to me. Click on that, and we'll talk more about that later if the need arises. And the third one will introduce you to this new newsletter that we're going to be writing and sending out bi-weekly to all of the people that sign up for it. We will talk about that maybe later on as well. But there are those three options available to you, so please click on them.
Alright, I'm going to thank Miss Megan here for gifting us. They gave us some gifts. They asked a couple good questions here as well, so we're going to answer them real quick. They said, can a dermoid cyst affect fertility or changes of getting pregnant?
Very good question. If you've got a space-occupying lesion, which is what a cyst is in the ovary, it can be dermoid, in which case it's a tumor. It can be a functional cyst, which is large, or it can be even due to endometriosis, where you get a collection of blood in the cyst, which decomposes till it gets to look like melted chocolate. We call it a chocolate cyst. And if you get a dermoid cyst, any cyst in the ovary, it acts as what I like to call a misfit tumor. It activates the connective tissue in the ovary, outside of the follicle, to overproduce the male hormone testosterone. Now don't get me wrong, you must have some testosterone produced by the ovary to make follicles grow and eggs develop. Without it, it won't happen. But you don't want too much, and if there's too much, it has the reversed effect. It compromises growth of follicles, compromises development of the egg in the follicle, and you end up with getting poor results from that ovary. So if there's any cyst that's more than 2 centimeters in size, in my opinion, it needs to be removed or dealt with. And we'll talk more about this later on, how we deal with the endometriotic cysts, also known as endometriomas or chocolate cysts, using a new procedure that I introduced some 15 years ago called sclerotherapy. And it's a non-surgical approach which gets as good results as you get from surgery, and you don't lose the eggs and the ovarian tissue that you often lose with surgery. So if there's a cyst in the ovary, for that reason alone, because it can interfere with your fertility by causing increased ovarian testosterone production, which gets into the follicle and compromises egg and follicle growth. And then there's the risk with the dermoid that it can go malignant. A small percentage of dermoid cysts, and these are cysts that have got different tissues of the body in them. They've got tissue oftentimes there's a tooth in it, or there's a part of lung tissue, or there's a part of a kidney tissue, or there's skin, or there's hair. These are all things you find in a dermoid cyst. And one of those tissue types can go malignant. Not commonly, but it can. And it's important to get that cyst out before any of these things go malignant and cause serious risk to your health and well-being. So yes, a dermoid over 2 centimeters in size, in my opinion, needs to be removed. And like with the endometriotic cyst, it needs to be removed at least 6 to 8 weeks before you go into a cycle of IVF stimulation.
Alright, we're going to answer Flavorsome. They said, I have endometriosis, tried hormonal contraceptives, a coil, and sorry, I just closed the message by accident. And sorry, I don't know why it's not opening now.
Come back to it.
Right there. And it says coil, but nothing working. I am 40.
Well, there are a couple of issues here. You've got endometriosis, which we're going to talk about in a few minutes. So please, those of you that are there, stick around for this presentation in about 5 minutes from now. But if you're taking hormones, using a coil or using hormonal treatment, it's not going to do anything to help you get pregnant. It's something you sometimes do in advance of going into treatment for endometriosis, but that treatment alone with a birth control pill or hormonal treatment is not going to alter or reduce the impact of the endometriosis on your fertility.
Alright. Let's answer one more and then we'll do a little speech here.
You can go to sleep then, Josh. You don't listen to this.
Let's do, I just had it here. I span, they said, I had a chemical pregnancy and a miscarriage 2 months in a row. Is it fixable?
Depends on the cause. The cause can be that there was something wrong with the egg that resulted in an abnormal, genetically abnormal embryo, and that is the commonest cause of miscarriages, chromosomal and genetic problems of the embryo. But it can also be that the embryo was good, but the uterus was not receptive because of underlying problems, one of which is immunologic, which occurs in a third of women with endometriosis, or it could be due to there being little polyps or growths growing into the inside of the uterus, causing an irritation of the lining and evicting the embryo, or it can be due to fibroid tumors that grow from the wall of the uterus into the cavity. If these lesions are confined to the wall of the uterus but don't grow into the cavity, they usually don't cause problems. But if they do, they'll irritate the lining and evict the embryo. So the cause can be embryonic. 80% of the time it's due to the egg being the problem. And it can be due in 20% of cases due to the uterus not being receptive to the embryo. The seed is the embryo, the soil is the uterus. You can't plant a good seed in a bad soil or a bad seed in a good soil. So we need to identify what the cause was of your miscarriage before a particular treatment can be directed towards you.
I just want to answer this last one here. Sorry, it's a good question. It says, I have no kids yet. Is it safe for me to go for a large endometrioma surgery?
Wow, well, we're going to get to that in a few moments. I'd like to defer it, but please stick around for me to address that.
Perfect.
Is this a good time for me?
Yeah.
Okay. Let's talk for a few minutes about endometriosis, which is a chronic gynecologic condition where the lining of the uterus, called the endometrium, grows outside the uterus, usually in the pelvic cavity, although it can spread beyond the pelvis into other parts of the body. Here's what happens in nature. The lining of the uterus is the endometrium. 2/3 of it is menstruated away every month. It's also the functional layer where the embryo attaches and where the baby grows and the placenta develops. So ordinarily, when you menstruate outwards predominantly. But almost all women who menstruate at some time or another will also menstruate backwards through the tubes. Now you may know the tubes hang over the ovaries like shower heads. So the menstrual blood drips out of the ends of the tubes into the pelvis. In fact, if you look inside the pelvis and you're doing a procedure called laparoscopy during menstruation, you can usually milk this menstrual blood and tissue out of the ends of the tubes, and they drip into the pelvis. Because the ovary is right next to the ends of the tubes, the first structure that's affected, that it comes in contact with, is the ovary. Now this menstrual fluid, this menstrual blood, contains not only blood, but also the tissue of the endometrium, which in most cases contains live cells and tissue. And they attach to the membrane that envelops all of the pelvic organs, known as the peritoneum. And they grow there. They love to grow on the peritoneum. At first you can't see them. They're invisible. They're translucent. These spots grow, and then what happens is the woman will ovulate in the middle of the month, and when she ovulates, she starts to produce a hormone called progesterone, which signals her immune system to send little janitorial cells to the pelvis. Through that membrane, they go in and they gobble up these deposits like little Pac-Men. Those of you who are old enough will remember the game Pac-Man. They gobble up these deposits and spit them out. And when the period starts again, you have it starting all over again. So what I'm describing is a normal physiological event that almost all women who've got at least one open tube will go through repeatedly in their reproductive lifespan. Now in certain women, and we don't know exactly why, but there's a strong suspicion that it has to do with women that tend to have a slightly higher level of stress that they live in. Women that are type A personalities, take charge individuals, people that are a credit to their gender. They usually are the professionals in their career. The type of woman that goes to Google and everywhere else they can go to get as much information as possible about any problem they're having fertility-wise. They are Google exploiters. These women live at a slightly higher stress level, and we think, I certainly believe, that this higher stress level tends to suppress the immune cell clearance of these deposits, because these are the very women that later on tend to get endometriosis. So in these women, many of these deposits that you can't see now grow, and not all of it is removed by these immune cells or macrophages that go down to the pelvis and clear out these deposits. They grow, and then eventually they bleed into those little deposits when the woman menstruates. And they expand, they stretch the membrane that envelops the pelvic organs, known as the peritoneum. The woman gets pain, congestion, heavy bleeding, pain with intercourse, and pain with ovulation. Those are typical symptoms of what happens when they stretch. And they start becoming confluent. And as they do, what happens is they release toxins into the pelvic cavity, into the secretions of the pelvis. So here's the egg in the ovary, perfectly normal, developing normally, trying to get across the gap into the tube, which helps by picking it up, goes into the tube to meet the sperm and be fertilized. And in the process of crossing through this toxic peritoneal environment, the membrane, or the envelopment around the egg, which is like the shell of a chicken egg, but only the egg is as big as a grain of sand, becomes impervious to the sperm entering it. So what was a good egg when it left the ovary, by the time it gets to the tube, can no longer easily be fertilized. The sperm can't get in. And so the chance of that egg fertilizing is probably around 4 to 6 times lower than you'd ordinarily expect if there wasn't any of this problem. Now I want to make a point. These toxins are released even before the lesions that you can now see in the pelvis, because they've had blood go into them, and when the period stops, this blood absorbs, but of course blood contains red stuff called hemoglobin, which is an iron compound, and now stays behind as a pigment in that area where that deposit was. And when you do a laparoscopy at that point and look inside, you see these little gunpowder-like burns all over the pelvis, or pigeon eyes looking back at you. These are nothing more than the iron pigment hemosiderin remaining in that little deposit, leaving the telltale sign that that's where that little endometriotic deposit developed. But you've got this problem long before you can see these lesions. If you're destined to get it, you'll present with infertility before those lesions can even be seen. So now what happens is you've got a toxic impact affecting the ability of the egg to be fertilized. So that is why in women with endometriosis and those destined to get endometriosis and to be able to show those lesions as time goes on, will have a 4 to 6 times lower chance of getting pregnant per month of trying. So if you have a woman of 35 years of age who ordinarily should have about a 15% chance of having a baby per month of trying, now if she's got even preclinical endometriosis, the chance of conception is going to be 2 or 3%. And that explains why one of the commonest causes of unexplained infertility is endometriosis. Now sometimes the egg does get across, fertilizes and makes a baby, and the woman gets pregnant in spite of this problem. It's not an all or nothing phenomenon, but it's so much more difficult to get pregnant, and that woman then goes on and has a baby, and a doctor says to her, you know what, the way we got you pregnant was to give you Clomid, or give you letrozole, or give you injectable fertility drugs. All we got to do is do it again and you can get pregnant again, and they miss the entire point, which is that that toxic environment is there for life. So every time an egg tries to get across to the tube to fertilize with the sperm waiting in the tube, that egg is compromised, and that is why endometriosis is the commonest cause of secondary infertility. The woman gets pregnant and then she can't. And it usually is that there was endometriosis causing this toxic effect. Very important to understand that endometriosis is very common in women, therefore, who've had a baby and then can't get pregnant again. And whenever that happens, especially if the symptoms are there, painful periods, painful ovulation, heavy bleeding, and pain with intercourse, that will very often be endometriosis. Now, if the doctor then goes and says, you know what, I'm going to do a laparoscopy to look inside the pelvis to see if I can see it, He maybe won't see it, and maybe he will. Doesn't matter how mild the endometriosis is, if the tube is open, if the tube's open, the reduced fertility potential is there in all cases. And there's nothing you can do to reverse it. Now think carefully. If you go and do something called intrauterine insemination, or IUI, which doctors so frequently recommend for women who've got open tubes and who are ovulating, even if they've got mild endometriosis, your chance of getting pregnant is no greater than doing nothing. And if you get pregnant with the fertility drugs and or with intrauterine insemination, a procedure that I introduced into the field of medicine approximately 30 years ago, and which we're going to talk about with at the next live feed in big time next Saturday. If you do get pregnant with fertility drugs, it's in spite of it and not due to it. And if you take the same treatment again, you're not more likely to get pregnant than if you ovulated on your own. Same way, surgery. You go in to remove these deposits, you will only remove those you can see. And for everyone you see, there are another 15 or 20 coming up. Give them time, they'll be there. And in the meanwhile, they're still creating this toxic environment. And that is why surgery, laparoscopically, to laser away or burn away these deposits, will not improve the chance of pregnancy over no treatment at all. If you get pregnant after surgery, it's in spite of it and not due to it. And that is why I tell people with endometriosis, you may need surgery because of severe complications, such as pain, or you need a large lesion removed, but it is not a treatment for the fertility. Surgery will not improve your chances of getting pregnant over no treatment at all, and it's not, in my opinion, the ideal thing to do if you've got endometriosis. Now, two other quick things. I've just spoken about the toxic pelvic environment, which occurs in all women who are getting or have endometriosis, making the performance of fertility, giving fertility drugs to make you ovulate and release more eggs. They're not more likely to get fertilized. They've still got to cross over this toxic environment, and that's like trying to swim across a river with alligators. You may make it to the other bank, but you're not going to usually be in a condition to make a trip into the interior. And that's exactly what happens as the egg leaves the ovary in early or later endometriosis. So it's really important to understand this, and it saves you a lot of misery and cost and pain. You don't need to do surgeries over and over. Today, we can diagnose early endometriosis without surgery. We can do a procedure called the receptiva test, where we test a marker in the uterus, and a little slither of the lining from the inside the uterus as an office biopsy can be tested, and within a few days you'll know if you have a positive BCL6 or receptiva test. And if it's positive, you either have endometriosis or you're getting it, or you sometimes have a condition called a hydrosalpinx, where there's fluid in the tube, but it's 95% accurate for endometriosis, and it can be done in the office. Surgery isn't necessary to diagnose the endometriosis, and it doesn't help removing the small lesions because you've not removed the release of toxins from all the others that you can't see and those coming up. Other causes of infertility with endometriosis can be scar tissue forming around the tubes which block them. And that often happens in the very advanced cases. But that is something that we're not going to go into in great detail here, because if the tubes are blocked, doesn't matter what did it, you need IVF anyway. Then there is one other condition where you get, we spoke about it earlier, the chocolate cyst or endometrioma, because the ovary is the first target of the implanting endometrial tissue, as I said, which causes endometriosis. It can form, and then you can bleed from the endometrial lining in the tissue that is in the ovary at that time, and it forms a blood-filled cyst which gets larger and larger with every period. This blood decomposes and gets to look like thick melted chocolate, hence the name chocolate cyst. The other name for it is endometrioma or endometriotic cyst. Endometrioma needs to be removed, otherwise the eggs produced in the ovary that's affected will be compromised, and you'll get many more of them being chromosomally genetically abnormal, unable to make a baby, and you'll get fewer eggs as well. So you've got to get rid of them. And you get rid of it 6 to 8 weeks before you do the cycle of ovarian stimulation. So the traditional way of getting rid of those cysts, those endometriomas, is to do something called laparoscopic ablation or laparoscopic removal. The doctor puts you to sleep, you go under general anesthesia, telescope-like instrument through the belly button, the abdomen is inflated with carbon dioxide, and under direct visualization you excise the entire cyst, or you laser away the inner lining that forms the blood with menstruation. So you stop the process. But the problem with that is it's a surgery, and in removing the cyst you often remove many egg-bearing areas of the ovary, and you reduce that ovary's number of eggs present. You cause more scarring, and it's painful, and you have to be in hospital. That's the way traditionally endometriomas are treated. They must be removed, or the affected ovary will produce poor quality eggs. Today we don't need to do surgery anymore. We do something called sclerotherapy, which I first introduced some 20 years ago. That is, you go in under ultrasound guidance with a woman under sedation or under local anesthesia. You put a needle into the cyst, you wash out all the endometriotic chocolate fluid, and then you inject a sclerosing agent into the cyst. I used to use something called tetracycline hydrochloride. It worked perfectly. I published on it. It was a good way to treat it. It would cause the cyst to collapse. The cyst would then disappear within a couple of weeks, and it gave you excellent results. But there was a problem. If any of the tetracycline leaked out into the pelvis, and that wasn't uncommon, you'd end up with severe peritoneal reaction, something akin to peritonitis. And we call it peritonism because it's chemical in nature, not infective. And that caused severe pain. And that lasted for many hours. And we'd have to observe the woman, and this occurred in about 10 to 12% of women undergoing what we call sclerotherapy for endometriosis. So we never pushed or promoted the use of sclerotherapy because it was so painful. Today, there's a new approach using ethanol, 95% alcohol, ethanol, and injecting that into the cyst after you've drained it. It does exactly the same as we got done with tetracycline hydrochloride, and it causes no side effects, and it's not dangerous, and it is an outpatient procedure. It's very inexpensive and highly effective, and you don't need surgery. But most important of all, you're not removing any egg-bearing tissue in the ovary, because you're simply introducing the ethanol into the cyst, and then the cyst collapses and absorbs. And in almost all cases, it is successful. It's certainly as successful, and maybe even better than surgery. The recurrence rate is no greater, and you don't damage the ovary. Today's sclerotherapy, in my opinion, is a game changer using ethanol. And we have a program at Sher Fertility Solutions in New York where we do sclerotherapy on women with endometriomas and avoid the need for any surgery. If you're interested in that, I urge you to give us your name and we'll send you more information. All you've got to do is email Paddy at concierge, concierge, concierge at sherivf.com, sherivf.com. All you do is send her your email and mention there that you want to go onto the list for further discussion about sclerotherapy as an alternative to surgery for endometriomas, and she will get that information to me. We'll discuss it and get back to you. But I urge you to do that because you don't need to do surgery any longer for endometriomas. The next thing is that, and then I'm going to stop there for a while, the next thing is another cause of infertility with endometriosis, is that a third of women with endometriosis have an immunologic cause for the embryo not attaching. Last week, and we put the entire presentation on YouTube, you can go and look at it there if you want to, we spoke about immunologic causes of failed IVF or failure to get pregnant. 1 in 3 women with endometriosis,
regardless of its severity, mild, moderate, or severe, will have immunologic problems that prevent the embryo from attaching. I'm one of the pioneers in this field of immunologic causes of failure to conceive with IVF or reasons for miscarriage. And if you want to talk to me about that, go to the bio, click on the link where it says you want more information, and we'll get back to you. But the most important thing to know is that this is treatable, removable, and if you don't treat it, here comes the big important point. If you do have this type of immunologic problem, which cannot be diagnosed in the everyday regular reference laboratory such as you have in your area, it's got to go to one of 3 laboratories that specialize in reproductive immunologic testing. Then if we find the cause and we can identify, quantify and typify it, which we will do, and we treat it, you can get a baby as easily with IVF as if you never had endometriosis in the first place. So from everything I've told you today about this, I'm sorry I took a bit of time, but it's really for those of you that want to go back and listen to this again. All this is in the articles that you can get free of charge by simply requesting, by going to the bio and requesting the 2 books plus the articles. I wrote a specific article on sclerotherapy and a specific article on endometriosis and infertility. All this is in there. I urge you to go there. It costs you nothing. It'll inform you. You'll become much wiser about your problem, and you'll have a much greater insight into what you must do. So really important. Go there and get this information. It's treatable, correctable, if you do the right thing at the right time. And then the very last point about all of this endometriosis and infertility is some women, the endometriosis is so advanced that it reduces the reserve of eggs in your ovaries and you develop diminished ovarian reserve. And that can be picked up when your AMH, your anti-malarial hormone level in your blood, is below 1.5 nanograms per milliliter or below 10 picomoles per liter, depending on where the test is done. And if you have diminished ovarian reserve, then you need a very individualized approach to ovarian stimulation. You can't use a one-size-fits-all, and that is really something I would need to talk to you about. Again, in that bio, there's an area that you can click, and it's merely to get more information, and we'll get back to you.
Alrighty, that was perfect. Just to read off some stats real quick, we have 120 people in the live chat right now with over 10,000 likes, so thank you everybody who's participating and actively commenting. We appreciate your patience. We're going to answer some comments now, so I'm going to go up to Hazy B. One of her comments earlier that she asked is, are there any risks to sclerotherapy?
The risks are minimal because alcohol injected into the follicle is not going to cause any side effects. The only risks are you may bleed if you hit a blood vessel, and I've never seen that happen. It's just as likely that that's going to happen when you take eggs out with IVF. There's a risk of infection whenever you put a needle into the ovary, but that is no greater than when you do IVF egg retrievals either. There's always those risks, but they are minuscule. Now, in the old days when we used tetracycline hydrochloride, there was the risk of terrible pain and peritonism. We don't see that anymore. It literally is a tea break type procedure, an outpatient procedure.
Alright, I'm going to answer Miss, if I pronounce this wrong, I'm so sorry, Aleti Lewis. She asked a couple questions here. I'm just going to read them off real quick. It says, I have DOR, but was told my endo was really mild. I question if if a bunch was missed during lap. And then it says another question down here that she just asked.
Let's do one at a time. Can we do that?
Yeah, I think it's additional to her question, that's all. It said I had mild endo fulgurated. We're going to try naturally for a few cycles. Should we go for IVF?
I'm going to say this as clearly as I know how. I really want to get this across. I've taken some time to explain the toxic pelvic environment. I've told you that doing IUI, intrauterine insemination, a procedure that I introduced into the field of medicine myself in 1984, using fertility drugs or surgery, You may get pregnant after it, but it's in spite of the treatment. It's not going to, in my opinion, improve your chances of getting pregnant over doing nothing at all if you're ovulating normally on your own. Trying on your own doesn't make things worse, only it wastes time and is something you can't afford to do if you've got diminished ovarian reserve you describe as DOR. Because that means you're running out of eggs and you have got to make hay while the sun shines. So the answer to your question is simple. I'm not saying every woman with endometriosis needs IVF, because that would be wrong. You can get pregnant on your own. I'm saying your chances are so much reduced. And if you're older, over the age of 35, so now the biological clock is starting to impact on your egg quality and number. And if you have got diminished ovarian reserve, which means you're already running out of eggs, and in 1 year you could be flat out of eggs. You don't have time to waste. So the only thing that will improve your chances is to remove the eggs out of the ovary before they come in contact with a toxic environment in the pelvis, fertilize them outside the body, make embryos, allow the embryos to develop to the advanced stage known as the blastocyst stage by day 5 or 6. Do PGTA to check and make sure that the embryos that you've got are good. The ones that you've got, the older you get, the lower the chance of them being good. And if you've got diminished ovarian reserve, the poorer the chance, which is more of a reason to get to them quickly. Develop the blastocysts and then test them by PGTA. Freeze those embryos that are PGTA normal, store them for future dispensation. And in the meanwhile, you then have the ability to be tested for immunologic causes which occur in a third of women with endometriosis. Because if you have those immune problems where you've got increased activated natural killer cells, again, this can't be measured adequately in your local lab. It's got to go to 1 or 3 or 4 labs in the United States that can do these tests. If you've got this immunologic problem, we can then regulate it with treatments that proudly we helped introduce and develop in the field, which has helped thousands of women with endometriosis and other causes of natural killer cell activation have babies. We can deal with it and fix it, and you can go ahead and have a baby. But if you don't do IVF, you may get pregnant, but you may not, and you don't have the time to waste. If you're over 35 or you've got diminished ovarian reserve with an AMH of under 1.5 nanograms per milliliter or 10 picomoles per liter, if you've got a low AMH at any age, you don't have time to waste. You need IVF as a treatment of choice. But you don't need surgery to get to that point, as I pointed out earlier on. You can get to that point without surgery. And using drugs like Lupron to suppress the endometriosis will do no good, in my opinion. It may suppress development of these lesions in the pelvis, but I've just pointed out that's not the reason you're infertile. You're infertile because of the toxins these lesions produce. And that doesn't get help with using Lupron or Decapeptyl or Buserelin or Superfact, which are all the same type of drugs. So you don't want to use Lupron for a few months. It delays you, besides which it sends a woman into a pseudomenopause, lowers her estrogen level to the floor, and now the uterus becomes insensitive to estrogen. And when you want to put the embryo back, it won't respond the way it should. The lining remains too thin, and now you've superimposed problems. You've got good embryos, but you're putting them back into a thin lining that has been compromised by prolonged exposure to Depolupron. So very simply put, the only thing that helps is IVF. Provided you deal with the implantation problem, make sure there's no immunologic issue, and if there is, you deal with it up front before you put the embryo in the uterus. No point in doing surgery to remove endometriomas or endometriotic cysts or the lesions that are there, because that's not the reason you're not getting pregnant. Only time surgery is indicated is if you've got major complications from very advanced endometriosis, and that's a different matter, and in those cases sometimes using Lupron will help. The bottom line is that IVF is the only method known that improves the chances of success in women with endometriosis of any degree, and especially important if you don't have the time to sit around and wait for a fluke to occur for you to get pregnant, which is 4 to 6 times less likely than it would be ordinarily. So you don't want to waste time. You want to make hay while the sun shines, especially if you're running out of time. I can't emphasize enough how helpful it would be to everyone on this live feed to go to the bio, click on that option where you get 2 free books which talks about these immunologic issues, deals with all aspects of IVF including endometriosis, and then read the 2 articles that I've specially written for you, which will come to you with the books free of charge, and you'll have an understanding as to everything I've just spoken about and have a much better insight. And if you don't do that, you're going to fall into the category of many, many women that spin their wheels, waste time, waste money, waste emotion, and don't get there. You often hear many women who've told they've got mild endometriosis, and they're reassured that all they're going to do is keep trying and they'll get pregnant. They may, and they may be young enough to have the time to wait to see if it happens. And that's a perfectly acceptable option. But don't let anybody tell you that doing IUI, a procedure that I really am proud of because I introduced into the field of medicine, or doing surgery to get rid of the endometriosis or even the endometriotic cyst that you've got there is going to increase your chances. It's not. You need, if you want to get pregnant, and it's a priority to do it quickly, to do that which works quickly and which is most effective immediately. That is IVF. I'm not saying a young woman in her late 20s or early 30s needs to go straight to IVF, especially if she's ovulating normally with a normal AMH. She may want to try a few years on her own, but don't think by doing that you're improving your chances. Only IVF improves the chances.
Alright, we're going to answer some questions here. I've seen this person comment a couple of different times here. I'm going to summarize their comments. They said I had a laparoscopy when they were 13. They were too young. Sorry, I just lost it. Go back up here. They were too young. It was wrong. They're scared that they can't get pregnant. Is there any advice you have for them?
Well, it depends why the laparoscopy was done. You obviously never had endometriosis at the age of 13, but there may have been another problem, and without knowing what it is and exactly what was done, I'm not in a position to help.
I believe there was a comment earlier that said she also had PCOS.
That's a different story. That means now you've got an ovulation dysfunction. And if you've got PCOS, that requires a very, very different and specific approach to treatment. And we can talk about that if we have the time. Now, you had 6 over there, right?
I had what? Hold on, let me go to the question real quick. For this one here, let me see. You mentioned your upcoming Sher Fertility Compass newsletter. Is there any way that anybody can get a hold of that?
The newsletter I'm very excited about. It's going to come with a new article I write every week. I'm going to answer questions that are specifically directed to us. I'm going to tell you what's new and what promotional things are going on in Sher Fertility Solutions in New York. I'm going to tell you what the breakthroughs are and developments in the field of IVF. It's going to be really a fun newsletter which will come to you at first every 2 weeks and maybe later on, depending on my fortitude, every month. But every time you'll get a completely new article that I write specifically for the audience. Please, if you want to be registered to get this given to you, we do need your email address. So you need to send that email address to Patty, my assistant, my office manager, Patty Converse, and her email is concierge, concierge, at sherivf.com, sherivf.com. But make a special note of telling her that you want to have your name put on a register for the newsletter, and we will get them to you.
Perfect. Anna says, it won't let me pin her comment here, but it says Anna has stage 3 endo, a chocolate cyst on her ovary. She's done IVF, but her egg quality hasn't been good. is sclerotherapy an option, and if so, can she get your opinion?
Anna, we went through that a little while ago, a few minutes ago, about doing sclerotherapy for endometriosis. Yes, it certainly is a major game changer. Game changer. Do you know that 20 to 50% of women who are have infertility, have endometriosis as the primary cause or as an adjunct cause? And it's definitely something that you need to be thinking about. But I'd like to say this to those of you that may be interested in talking to me. And all you got to do, the second option on that, when you go to the bio, you'll see an option where you click on it and it says, if you want to talk to Dr. Sher, if you want to have an interaction with me one-on-one, that's where you go. Now, we will be more than happy if you have, I can just tell those of you, because I know it's going to come up if it hasn't yet, some of you have insurance that covers infertility treatment. And if you do, we've been around here so long doing this, almost certainly your insurance would cover such a consultation with me where we can get down in the weeds and I can help you better understand. That is really going to help people that are in the United States and have medical insurance that covers medical consultations in this arena. We can help you find out if you do. So if you fall into that category, very definitely all you've got to do is click on that link, and what will come up will be a questionnaire. Fill in that questionnaire. It takes 4 minutes to do. It'll immediately end up with Patty Converse, my office manager, and she will then reach out to you to set you up for a consultation with me online to have an in-depth discussion on your case. I can also say that for those of you that don't have medical insurance, I wish there was an easier way to say this, but unfortunately it's going to take an hour of my time to consult with you and an hour to prepare for that consultation, and unfortunately there is a nominal fee, and I think it's $250 or something, but that's not unreasonable. If you're still interested in talking to me, all you've got to do is let us know if you want to by clicking on that link, and you'll get that questionnaire answered. Patty will get back to you and you can make your own mind up if you want to have an online consultation with me to discuss your problems. This is especially applicable to the many of you that are from out of country.
We're going to answer Zilia here. They asked, oops, and I go back. It says, why is endometriosis so common?
Maybe there's a lot of smart people out there. Remember I told you, it more commonly occurs in women in the reproductive lifespan. It's more common in Caucasians. It's more common in people that have got a high IQ, people that tend to be type A personalities, driven, overachievers, people that are a credit to their gender when it comes to their professional achievements. Unfortunately, that same person is less likely to be able to clear the endometriotic deposits that occur in all women who've got at least one open tube intermittently, and they can then, those women can end up getting endometriosis for all the reasons I've discussed.
We're going to answer Bella here on TikTok. This says, does endometriosis laparoscopy or surgery cause infertility?
Does endometriosis laparoscopy
surgery cause infertility?
It should not, if the doctor knows what they're doing. But again, I don't know why you would even do laparoscopic surgery for endometriosis unless you've got a big tumor in there that's causing complications and problems, or something that's causing a lot of pain that needs to be addressed. Other than that, surgery for endometriosis as a preparatory to get pregnant through IVF is no longer, in my opinion, easily justifiable. It's far better to do sclerotherapy. It is going to be a game changer. I predict that 5 or 10 years from now, virtually every doctor doing infertility treatment and IVF will be doing sclerotherapy. We've got a lot of experience in doing it. We have a program that enrolls people into our sclerotherapy program. And if you're interested in doing that, as I requested earlier on, contact Patty, same email address, concierge@sherivf.com, and let her know of your interest, and we'll put your name down, get back to you, and discuss your opportunity of doing that with us. You need to be prepared to spend 2 or 3 days in New York with us to get the treatment done.
We're going to answer Kanya, or Kainat. They said, can semen cause endometriosis, or can semen cause endometriosis or blocked tubes?
Not unless it's infected. It can cause blocked tubes if you've got infection, because that's how sexually transmitted diseases reach the woman and damage the tubes. But it won't cause endometriosis.
All right, we're going to answer Miss Lewis here again. She said, are there any supplements for endo? What about GLP-1s?
In my opinion, there's no supplement known, nothing available that's going to get rid of endometriosis. That's why doctors tried using male hormone therapy, tried using the birth control pill to suppress the growth of these deposits, and used Lupron to try to make them shrink. None of those things get rid of the underlying problem, which is the toxic impact of the deposits in the pelvis and the way it adversely affects the egg leaving the ovary to get to the tube. And it's not going to change anything when it comes to doing IVF, which, as I mentioned over and over, is really the only way to improve the chances of pregnancy if you've got endometriosis infertility.
We got a couple of really good ones that just came through here. Okay, KM98 says, how can endo be diagnosed? Is it just an MRI? Or is MRI enough?
Okay, how is it diagnosed? First, you suspect it. In any woman of reproductive age, especially if her male partner is fertile and she's ovulating on a regular basis and can't get pregnant, 80% should be able to get pregnant within a year of trying. And if you don't get pregnant for unexplained reasons, endometriosis is high on the list of possibilities. Second, if you do a receptiva test, RECEPTIVA, also known as the BCL6 analysis, you'll be able to diagnose it with 90 to 95% accuracy without any surgery being done. Now obviously if you're doing surgery for another reason and you're having a laparoscopy and there are lesions that are visible, you'll have a diagnosis, but because you don't have them, as I pointed out earlier, doesn't mean you don't have endometriosis in the make. So it's really important to know that your diagnosis is primarily a high index of suspicion and then doing the BCL6 test, the receptiva test. An ultrasound will show endometriomas, the chocolate cysts that I mentioned. You will see them clearly. To anybody who knows what they're doing, they'll pick them up by ultrasound. And an MRI will also pick up an endometrioma very easily. But you don't need an MRI in most cases. All you need is to do an ultrasound examination. There are no other tests that you really can do that can get you closer to the diagnosis. Once you suspect there's endometriosis, and you realize from everything I've said that in the final analysis, when the rubber hits the road, there's only one way you can improve the chance of getting pregnant, and that's doing IVF, because it removes the egg before it's confronted by the toxic pelvic environment. And it allows you to fertilize it outside the body, test it to make sure it's chromosomally normal. It's euploid by PGTA, and then put it in the uterus. That's the only way to improve your chances. That doesn't mean to say everybody needs IVF. You certainly don't need IUI or doing surgery, because none of those things are going to improve your chances of getting pregnant over no treatment at all. You've got open tubes by doing an HSG or hysterosalpingogram. Everything else is normal. You can try for a couple of months or even a year or two if you're young enough and you've got normal ovarian reserve. You can try on your own. But when you get to 35 and at that point egg quality is declining because of wear and tear on eggs that have been in your body all your life, or at any age, no matter how young, your ovarian reserve is already declining based upon the AMH test, IVF becomes a priority quickly before it's too late and you run out of time. So the answer is IVF is the treatment of choice.
Coloring says, does endometriosis start from the first period every girl gets? So it's like something like an inheritance, question mark.
It's a good question. Is endometriosis inherited? It does tend to occur in families. There are many theories as to how it develops. Serosal, heteroplasia, genetic, and we can go into all of them, but the most important explanation is the reversed or retrograde menstruation through the tubes with these cells in the blood attaching to the surface of the peritoneum. Is it inherited? Maybe. We don't know for sure, but it tends to occur more commonly in families.
Jessica said, how does pregnancy affect endometriosis, where organs are stuck together from adhesions?
When you are pregnant, you don't menstruate. So there's no exacerbation or worsening of the endometriosis in the 9 months of pregnancy because you're not having any periods. There's no bleeding into these deposits. But the moment you've had your baby and you start having periods again, you're back at square one and you're back where you started. So pregnancy can put it on hold, but it's not going to cure it or improve it. You may feel better because you're not having bleeding into these lesions that are stretching the membrane and stretching the pelvic organs, so you may feel better, but it's not going to do anything to cure it.
Bree says, what preparation would you do for your patient with endo and positive TPO of 780 for transfer?
Okay, but now we got a different issue. You remember I told you 1/3 of women who've got endometriosis, even in its preclinical stage, will have an immunologic problem. It's a problem where we find something we call activated natural killer cells, which I spoke about at length in last week's live feed, and which is available on YouTube if you want to go there and look at it. But the bottom line is, women who've got TPO have also got an autoimmune condition known as Hashimoto's disease. And 50% of women, I repeat, 50% women who've got thyroid antibodies, one of which is TPO, and the other's antithyroglobulin antibodies, one of those women, 50%, will have the same immunologic problem that occurs with endometriosis. Both of them are imminently treatable. I had a woman, not a young woman, who came to one of my lectures I gave in Australia a few years back. She was a lung specialist. Her husband was a psychiatrist who, believe me, needed a psychiatrist, because he stood by and watched his 42-year-old woman, his wife, go through IVF 24 times and fail every time. She wanted a baby so badly, and so did he, that they sat through this. She had TPO antibodies with Hashimoto's disease, but she also had very severely diminished ovarian reserve, or DOR. She was running out of eggs. Her AMH was 0.1. Normal is over 2, acceptable is over 1.5. So 0.1 is terrible. So I gave the lecture. She came up to me and I told her that we could treat her, that I had been involved in developing methods of attacking this immunologic problem and solving it. She came to the United States. I got 3 eggs out of her because she didn't have any more. One of them was chromosomally normal by PGTA. We put that embryo into her uterus, treated her immunologic problem with intralipids, steroids, and Lavenox. She had a baby that same year. I'm the godfather of that child. So the answer is TPO antibodies cause failure of the embryo to attach in 50% of cases that they are present, using exactly the same mechanism we see in 1/3 of women who've got endometriosis as diagnosed by a BCL6 test, laparoscopically, pathologically, it doesn't matter.
Alrighty, I'm gonna answer this comment here. It says, I've done 4 IUIs already and nothing is working. They keep telling me to try again, but I don't know anymore. Can you review my case if I'm not in your state?
Absolutely, it would be a pleasure and a privilege. But I want to point out that my patients come from 70 plus different countries, and all my consultations are done online. So I spend an hour with you. All you've got to do, if you want to, is go to the bio, click on the second option, which gives you access to a questionnaire, which pops up immediately. You can answer it in 4 hours. It gets to us, and Patty will reach out to you. And we will then be able to have an online in-depth consultation. I've told you over and over, and I hope it hit home, IUI is not going to cut it if you've got endometriosis, which you might well have. So we should talk, but I urge you to reach out to me. And again, as I pointed out, if you live in America and you have medical insurance, the likelihood is overwhelming that we accept your insurance, and that could be easier on you. But if you don't, regrettably, it's an hour-long consultation, an hour long to prepare for it. So I must, and I have to, and I do, have a nominal fee of about $250 for that consult. So for those of you that are from out of country and want to talk to me, feel the need to have the consultation, be aware that there is a fee associated with that consultation. But if you're local and you have medical insurance and you're not sure if it's covered, call Patty, contact Patty, and she will basically go over it for you and find out for you. But definitely I am available for anybody who wants to have an online consultation with me by just clicking on option 2 on my bio.
Alrighty, perfect. We're going to answer SJH here. They said, what is a hidden sign of endometriosis? What's a hidden sign that a girl might have endometriosis?
The hidden signs are your symptoms. Firstly, that you've had trouble getting pregnant in spite of trying regularly with a man that's fertile, where you are ovulating normally on your own. So you should be pregnant approximately 20% of the time per month of trying and 80% of the time per year of trying. And you should get pregnant if there wasn't a problem. So if there's no explanation for your not getting pregnant with regular exposure, with proper timed intercourse, clearly endometriosis is somewhere at the top of the list. And people may tell you you've got unexplained infertility. There is no such thing. There's always an explanation. We might not always be able to identify the cause, but in most cases we can if we evaluate you carefully. So the answer is, if you're not getting pregnant on your own, that's a first giveaway. Second, do you have certain symptoms that are typical with endometriosis? Not all, but one or more of the following. Very painful periods, pain with intercourse, with deep penetration, usually just prior to your period coming, heavy periods with prolonged bleeding, and pain in the middle of the month when you ovulate. Those are other symptoms that are very suggestive of underlying endometriosis. Those are the common hidden signs that you got to look for.
We're going to answer HMS on TikTok here. They said, is it possible that endo is gone after birth? They said, because I don't feel the same pain like I did before.
You're very lucky, but again, pregnancy will not cure endometriosis. It may put you in remission for a while, but it will come back because you're doing nothing to prevent bleeding occurring into the same lesions after the pregnancy is over.
Alrighty, let's go up here.
But nothing is absolute. I mean, these are important things I'm telling you, but there's no such thing as everything being the way I say it is just because I say it. I'm giving you what I have gained in 40 years of experience in this field, and having helped more than 17,000 women achieve pregnancies through IVF and IUI. So please, again, I'm saying IUI because I'm the one that introduced IUI into the field of medicine, and it's now used all over the world. It's a great procedure, but unfortunately, as you will learn if you come to my live feed next Saturday, where I talk about IUI, it's an overused procedure with the wrong expectations when it's used in women that are older or women where there's male infertility or cases of endometriosis.
We're going to answer Mary here. Mary said, what protocols would you follow for an endo patient?
It depends on everything other than the endo. The protocol of stimulation is dependent upon the woman's age, how she's responded before to fertility drugs, and her ovarian reserve, what her AMH is. And also, is there a male problem or not, and if there is, what type of problem. So each case has to be individualized. I cannot overemphasize how important it is to individualize treatment in patients with infertility. You cannot use a one-size-fits-all approach. If you have been through all these things and you're unable to have been successful, and for any of you out there, that feel that you might benefit from talking to me, hit option number 2 on the bio. You'll get the questionnaire crop up, fill it in, it'll go to Patty, and she'll get in touch with you and discuss with you the possibility of having a 1-hour online consultation with me, and we can discuss your situation in detail.
I'm going to answer Miss Tara here. They said, I've had miscarriages, I've had a 15-year-old, but never been able to conceive since. Is it possible they have endometriosis?
It's possible, but the fact that you had repeated miscarriages make it less likely. Yes, endo can cause miscarriages, but they don't occur repeatedly. So if you've had repeated miscarriages, it's usually not due to endo, but it could be due to something that's causing an implantation problem, which endo is one of them if there's the immunologic issue. But usually repeated miscarriages occur with a much less common form of immunologic implantation dysfunction than the one caused by endo, one caused by Hashimoto's, hypothyroidism, rheumatoid arthritis, and other autoimmune causes. It's usually caused by what we call an alloimmune cause. If you go to my bio and you go to option 1, which everybody attending this webinar should do, because it's free, and we will send you 2 books, one on IVF, and where are they here? These 2 books, they'll come to you as free downloadable ebooks. The thin one talks about the immunologic causes of repeated miscarriages, and the other book talks about all of the other things. I urge you to get those books and read up on this very issue.
Alright, we're going to answer Millennial Mums. She said, how successful is pregnancy after surgery and removal for endo? I'm 36 and I already have 1 child, trying for a second.
I think I mentioned it earlier on. Surgery is rarely helpful in improving chances of getting pregnant with endometriosis. The surgery, if of course it's a large lesion or a big tumor in the pelvis, or you've got intractable pelvic pain and you're having for that, surgery may be indicated, and even using Depolupron or using other agonists may be helpful. But for infertility with endometriosis, surgery in and of itself, in my opinion, is not indicated, especially since the advent of sclerotherapy to deal with cysts, endometriotic cysts or chocolate cysts in the ovary, which I went over in some detail earlier on. By the way, for everybody watching this particular long webinar will be posted tomorrow on YouTube, and you'll be able to look through all the stuff and go over it again.
Yes, sir. And for anybody looking for Dr. Sher's YouTube, it's the same @handle as his current TikTok and Instagram. It is @Dr. Jeffrey Sher on all platforms. If you missed last week's or the weeks before live stream, go ahead and go to YouTube, and the full live stream is there. We do record all of these. We're going to answer Molly M97. She says, shoulder and rib pain that comes with my cycle only occurred for last 3 months. Is it possible that's endometriosis?
Yes, it is. It is possible. In fact, sometimes if bleeding occurs in the pelvis and it tracks up above the liver, there's a nerve at the base of the diaphragm just above the liver called the phrenic nerve. And that nerve gets irritated if there's some bleeding that tracks up in the pelvis to the top of the liver. Typically it's the right shoulder that's painful, not left, right shoulder to pain. And it's made worse by breathing. But it's the right shoulder to pain, and it comes at the time of the period.
There's another question right here. Can endometriosis be located at other places besides the uterus?
Yes, I've seen endometriosis in the elbow. I've seen it in the lung. I've seen it in the belly button. I've seen it occur in the brain. Those are extremely rare manifestations. It can spread via the bloodstream or the lymphatics to reach far distant areas. It can be in the liver. So yes, endometriosis, endometriomas and deposits can occur anywhere in the body. They're very tough to treat though.
We're going to answer Jasmine here on TikTok. She said, I've mild endo, low thyroid, or plus low thyroid. I have an IVF cycle, received 21 eggs, none were mature. Is this endo?
No, let me explain. If you made that many eggs, it often means that the person has got a high AMH, anti-Mullerian hormone, above, let's say, 3 nanograms per milliliter. Women like you have got a tendency to hyperstimulate and are also at risk of severe ovarian hyperstimulation syndrome if too many follicles develop and they grow too large. Because those follicles also produce certain toxic vasoactive substances that cause leakage of the plasma in your blood out of your blood vessels into the surrounding abdominal cavity. The abdomen swells up with fluid in it. It's called ascites, and you start getting symptoms of shortness of breath if it's pressures on your diaphragm, and many other things can happen. But the most important giveaway is that there are large numbers of follicles. The estradiol level rises very quickly, and the number of follicles seen, not the eggs, the number of follicles seen go up above 20. So if that happens, you're at risk of developing a condition called severe ovarian hyperstimulation syndrome, or OHSS, which is life-endangering. The problem is that when a doctor sees that coming, he wants to stop it in its tracks. It's a nightmare for a doctor to have to deal with a patient whose life is endangered by being hyperstimulated through the very treatment we give the patient to getting the eggs. So the doctor will usually trigger you early on before the follicles get too many or too large, in the hope that he'll stop the process. And he will. But the problem is the eggs aren't ready to be harvested. So the eggs come out and they're all immature, or they aren't of good quality, and upon fertilization they won't make chromosomally normal, PGTA normal embryos. So when you are dealing with overstimulation, as you might well have done, it could be due to an underlying condition like PCOS or some other tendency to make you produce a large number of eggs, and the endometriosis may be coincidentally present. So if your doctor triggered you early to get the eggs out early, through that very act of removing them too soon, it's like picking plums off a tree before they've been able to develop properly, thinking if you put them on the window shelf they'll ripen and taste good. They won't. Your eggs are your plums, the ovaries are the plum trees. You've got to let them grow adequately, and the risk of hyperstimulation increases the more you stimulate. So in those cases, doctors do one of three things. They either stop the cycle completely, and if they don't trigger you with HCG, you're out of risk, it'll all be gone within 10 days, or they will trigger you early to stop the eggs developing more and getting larger, so that these vasoactive substances don't get released in excess. Or thirdly, they will use a drug called Lupron, or another equivalent like buserelin or Superfact or Decapeptyl, to trigger you rather than using HCG. That does reduce the risk of OHSS, but it comes at the expense of the eggs, because it doesn't help the eggs ripen as well as when you use HCG alone. So for that reason, it may have been the length of time you were stimulated, the type of protocol that was used, the method they tried to use to try to prevent a catastrophe, or the use of the wrong trigger. All of that could have caused your problem. Endometriosis isn't the reason. All you need, if you've got endometriosis, knowing that you have a predisposition towards developing a very high stimulation, is to get a very individualized approach to ovarian stimulation by someone that really knows how to individualize and strategize properly. So you may be someone that could benefit by us talking. And if you feel you would, simply go to the bio, go to option 2, click on that option 2, get the questionnaire to pop up, fill it in 5 minutes, it'll come to me, and then if you're interested in talking to me, you can simply have Patty get back to you, and she will set that up for us.
Perfect. We're going to answer Miss Charlotte here. It says, my partner has endo and got offered IUD, but doesn't know if this will actually help.
IUD?
That's what I have on. It might be
an intrauterine device. That's what an IUD is.
That's what's
That's used for contraception. If you mean IUI, that's a different matter. We spoke about that earlier. It's not going to help. But an IUD is to prevent pregnancy. I don't know why they would use an IUD unless they were thinking of putting in a progesterone IUD to try to lower the symptoms. That can be tried, but I don't think that's a very advisable or beneficial way to deal with your problem or with your partner's problem.
We're going to answer Jess here on TikTok. She said, I'm a 26-year-old midwife with severe endo and PCOS. How can I improve my chances of natural conception?
I don't want to pop your balloon. I don't want to make you unhappy, but I've got to be transparent and honest with you. If you've got advanced endo, the likelihood, it's possible, of you having a viable pregnancy on your own is not on the cards. You need to be looking at the alternative, which is to use IVF if you want to get pregnant. That's the only way you'll improve your chances. I've been through this, and I urge you, if you haven't yet, if you didn't attend that section I spoke on endometriosis and how it affects fertility, I urge you to go back to my YouTube tomorrow when it's posted and listen to it again. But you're not going to get pregnant easily with anything other than IVF if you've got endometriosis that is so advanced. Maybe we should talk. Maybe going to the bio and to option 2 and clicking on there and letting the questionnaire pop up. And then filling it in 5 minutes can get us together for a 1-hour online consultation for me to go through this with you in detail and help you with your problem.
User 35, well, let me pin them. They asked, what is involved in your books and your articles? They said, what is involved in your books and your articles?
Involved?
Like what is the books and articles about?
Okay. The one book is a book on IVF itself. It is called From In Vitro Fertilization to Family. I talk about every aspect of IVF and also intrauterine insemination, IUI, which I introduced into the field of medicine some 40 years ago. So it talks about all these things in detail. Each chapter stands alone, and you can read it separately. You don't have to read everything. The book is free. It's available to you by simply clicking on option 1. The second book is on the immunologic causes of failure to conceive with good embryos. A lot of people have embryos put in their uterus that are good, but they still don't get pregnant, not because there's something wrong with the embryos, but because the uterine lining is not receptive and you can't plant a good seed in a bad soil. So this talks about those with a special emphasis on the immunologic factors which are so often overlooked and are so misunderstood by the vast majority of people practicing in this field. So the second book's on implantation problems that lead to repeated miscarriages or that lead to unexplained IVF failures. And that's this thin book here. Read that book. It's only 50 pages long. It'll answer your questions, I think.
Awesome.
Oh, let me get some one of these tissues.
We're going to look for a question here in the meantime. Once again, thank you all who are joining us today. There's over 20,000 likes. We're so appreciative for that. And then over 110 people right now in the chat. So thank you all for being here and asking your questions. We're doing our best to answer as many as we can. If we don't get to your question today, please go comment on one of our most recent videos and we'll make it into its own video and answer you or DM you directly. I'm going to answer this one here. It says, do you recommend hormonal or natural hemopathic treatment for endometriosis?
You put me in a tough spot because my daughter would ask the same question because she's very much into homeopathy. And by the way, I'm very much in favor of naturalistic medicine. I don't think we've got all the answers, and I think many of the things that you get in homeopathy are also very, very helpful. Some of them poorly understood because they're not fully investigated. I went to China many, many years ago and watched them perform a hysterectomy and a cesarean delivery under acupuncture. I watched the use of natural substances to treat disease and saw some amazing results if what they told me was correct. So I'm not a critic, but in my honest opinion, I've got to give you my opinion as it stands. This is not going to help you get pregnant. You can delay things, you can put them off, and eventually you'll turn to what works, hopefully not at a point when it's too late. So I don't think that what you're contemplating, in my opinion, is going to play a big role in helping you go from infertility to family.
I'm going to answer Miss Madison Taylor. She says, what do you think the cause of endometriosis is? Is there any theories?
Nobody knows the exact cause, but yes, there are theories. And in my article that I give you, the one article you get by option 1, which again, everybody should go to option 1, it doesn't cost you anything. It just educates and inspires. There are many causes. I've given you one. The one is the theory of retrograde menstruation. Menstruating backwards through the tubes, and that's the most popular theory. That some of the cells are alive and they grow onto the surface of the membrane called the peritoneum that envelops the pelvic cavity, and I went into that early on in this presentation. The other one's a thing called serosal heteroplasia, where cells that are on the surface of that membrane that cover the pelvic organs undergo changes and turn into endometrial cells under stimuli that are poorly understood. Another theory is genetic. Again, that's like a big black box. Nobody can answer that question as to whether or not it is a factor. There are other theories as well, and my article that I'm giving you goes into them. But nobody knows for sure the cause. What we do know is that when it happens, it reduces your ability to get pregnant per month of trying. That means it reduces fecundity. It doesn't cause sterility. Women with endometriosis do get pregnant on their own. It's just a hell of a lot more difficult, and very often if you're older or you're running out of eggs, you've got diminished ovarian reserve, you haven't got the time to wait for that to happen. And when that happens, the only thing that's going to improve your chances of getting pregnant is IVF, because you're bypassing the toxic pelvic environment, any scarring that can occur in the pelvis. You're removing all those things, and you're able to identify and qualify and typify each fertilized egg or embryo by doing PGTA and putting the embryo in the uterus. So for those of you that don't know, PGTA is a genetic test where we count the chromosomes in the cells of the embryo that has reached the advanced stage of development called the blastocyst stage by no later than day 6 after fertilization has taken place, either in the petri dish or by ICSI, where you inject the sperm into the egg. So it is PGTA. We shave off a few cells from the outer layer of the embryo without damaging it, send it away, and they count the chromosomes. There need to be exactly 46 chromosomes in those cells, which then reflects, in most cases, what's going on in the embryo itself. If there's even one more or one less, it is known as aneuploidy, or embryo incompetency, and such an embryo in most cases will not propagate a viable pregnancy. Whereas if those cells all have 46 chromosomes, all 5 or 6 that you analyze by shaving off those cells off the end of the embryo, the blastocyst, that means that the embryo is euploid, and it helps you tell also if those embryos are male or female and whether they're normal or not. If you put one such euploid competent embryo into a uterus that is either receptive, in other words, you've ruled out anatomical lining issues or irregularities in the cavity of the uterus, and you've ruled out an immunologic problem, or you treat them successfully, then one embryo that is euploid by PGTA placed in the uterus should make a baby roughly about 55 to 60% of the time. And that's 3 times greater than your chances of a pregnancy occurring in your 20s on your own. And by the way, even if you're older, where you'd expect the embryo to be of poorer quality because of wear and tear, even if you're older but the embryo is chromosomally normal, it should give almost the same chance of pregnancy. The only problem is that as you get older, the chance of any given egg that makes the embryo being able to propagate a normal embryo declines rapidly. And also in women who've got diminished reserve, where the AMH is low. And that is why when you're over the age of 35 and certainly over the age of 40, or you've got diminished ovarian reserve, You don't have the time to waste waiting to see whether a miracle would happen. So for those reasons, PGTA is a test we do to tell which is the best embryo. And one last point, PGTA does not make better embryos. It identifies the good ones, so it's a selection process. It doesn't make better embryos, it gives you the ability to select the one you want, and even the gender or the sex of the embryo you put back.
We're going to answer you.
Oh, by the way, sorry about that, Josh. I may mention, I and my partner, Dr. Drew Tortoriello, the medical director in New York at Sher Fertility Solutions, introduced PGTA into the field of medicine some 20 to 25 years ago. It's now used all over the world. We developed the methodology to test, which has been improved upon by newer upgrades, but the concept and the treatment was introduced by us, and so we've done a lot more than just about anybody else in the world of the PGTA testing. Now again, being able to do the testing doesn't make better embryos. What makes a better embryo is putting a PGTA normal embryo into a uterus that is receptive or rendered receptive by medical testing and treatment.
Alright, I'm going to answer user 256 here. They said, they told me I have suspected endo but won't diagnose me or help. What can I do?
Tell the doctor to do a receptiva test. Very simple, in the office. And if he or she won't do it, find another doctor. There's no justification for refusing to do the test on you.
Gina on TikTok here says, hi Dr. Sher, where are you located and how can I have a conversation with you?
Gina, I'm talking to you from Las Vegas. I've just come back from New York, so I kind of spin around the place. But if you need to talk to me, the easiest way to do it, Gina, is to go to my bio. The second option there will bring up a questionnaire which is very brief. It's only 5 minutes, 4 minutes long. You fill it in. The moment you hit the button, it gets sent off to Patty, and when she gets it, she'll be back in touch with you to discuss things. Before you make a decision to do that, please look at your own situation. I don't want you to have any hardship. If it turns out you've got medical insurance, it's almost certain that we will accept that as full compensation. And I will spend over an hour with you, or as long as it takes, to walk you through your problem. But that's something you talk to Patty about when she reaches out to you. You're never under pressure. Never under pressure. Nobody will solicit you in this environment.
Alright, Miss Shania here says, surgery didn't help to remove endo. I live in chronic pain. What else can they do?
Surgery didn't help her for her pain.
That's what it says,
Well,
for endo, or to remove... surgery didn't help to remove endo. I live in chronic pain. What else can they do?
Well, there are a couple of choices. It depends whether you're still trying to get pregnant, because if you don't want to get pregnant again, you'll do what my daughter eventually did. Ended up having a hysterectomy, and the ovaries, one ovary was retained, and her uterus was removed, along with the tubes, and the pain was gone. So surgery is a way to go. There are a handful of outstanding endometriosis surgeries in the country. The one that I recommend the strongest is in Palo Alto, and he is able to do the surgery. He operated on my own daughter. He's extremely good, and he is the guy to do it. And we can give you his particulars if you want to reach out to us. The other thing you can do is have surgery where they don't remove the uterus, but what they do is something called a presacral neurectomy. P-R-E-S-A-C-R-A-L, neurectomy, N-E-U-R-E-C-T-O-M-Y. They cut the nerve that carries the pain fibers into the pelvis as it comes over the top of the tailbone, the sacrum. And then they take a little small segment of it out, so there's no pain fibers to the pelvis, and the pain disappears. But it doesn't cure the condition, it keeps on going. And when you do that, you have to have regular checkups to make sure, without you knowing it, that it's not getting out of control. So you do a checkup every year by ultrasound, maybe MRI, physical exams every year, but it will alleviate the pain.
Perfect. We're going to respond to MD. They said, I've got endo, don't want any more kids. Now they are saying I need to have a Marina coil. Please suggest. Do you have any suggestions for them?
Well, the Marina coil is nothing but a coil placed in the uterus with progesterone in it. In many cases, the periods stop, and with no bleeding, the pain doesn't get worse. And if you're okay, that may be an option. The other way to go is to go onto a birth control pill, a progestogenic birth control pill, like Overall, and that's an example of one. Desigen is another, which will stop you from having heavy periods. It'll alleviate the pain somewhat. Truth be known, at the end of the day, if you are still having pain, then the options that I just mentioned to the previous patient of actually doing a hysterectomy or doing a presacral neurectomy may be worth considering. And there are other medications you can do. You can get onto male hormones or androgens. That will also reduce the pain problem.
We're going to answer Seri M on TikTok. They said, what do I do if I have endometriosis and was, sorry, let me open it back up, blessed with a daughter through IVF? They've already had a kid, they have endometriosis. What can they do now?
If you want another kid, you need to do IVF again. If you don't want another kid, then you need to start thinking of how to prevent yourself getting pregnant, because endometriosis won't prevent you getting pregnant. It may reduce your chances of getting pregnant per month on your own, but it's not going to keep you contracepted. So that's something you then have to consider.
Z on TikTok says, hi, I have endometriosis but not severe. I'm ovulating but my progesterone was low. How can I help FH?
I went into this in some detail. You obviously were not present at the beginning. Please, tomorrow, when this particular webinar is loaded onto YouTube, and Josh will tell you again after this how you get there, go and look at it. It'll explain this to you. So, again, the question?
They have endometriosis but not severe. They're ovulating but progesterone is low.
I've told you that if you have endometriosis, you're going to have reduced ability to get pregnant, a 5 times lower chance of getting pregnant per month of trying. You may get pregnant on your own, but you're not likely to with endometriosis. It doesn't always prevent you getting pregnant. It reduces your fecundity, your chance of getting pregnant per month of trying. It doesn't usually make you infertile. On the other hand, you may have one of the complications linked to the immune system where your embryo won't attach properly because of an immunologic implantation dysfunction. All of this you'll find in these books. Here they are, these 2 books that I'm giving to you free, and the 2 articles that I give you free with the books, and they'll come to you free of charge by email return. All you've got to do is click on one of the options on my bio, and the first option gets you the books and gets you the articles free of charge. No pressure on you whatsoever. I urge you to do that, and I urge everybody else at this webinar to go in and get these books because they will help you. And by the way, give them around, spread them around. I never wrote them to make money out of them. I don't need to. I wrote them because I want my patients to have information that is correct, transparent, and informative to them. So spread them around, give them to your friends. Many of you are in groups where there's infertility. Spread the books around. They're only too happy. And please remember to tell all of your associates with a similar problem that we have these webinars every week. Now they're going to be every Saturday in general, but there'll be certain times when they're not on a Saturday, when they'll be in the middle of the week. I think Josh has those dates, but we can give them to you next week at the webinar as to when we're having them on certain dates, when Josh and I are not available to do the webinar, and we'll move it to midweek, and we'll still have the webinar for those of you that wish to attend on different topics. Next week on Saturday, I'm talking about intrauterine insemination. It's overused, used in the wrong cases. It often doesn't help, and it doesn't help women with endometriosis, for example. I'm going to talk about it because I was the one that introduced it into the field of medicine about 25, 30 years ago. I'm very proud of it, but it's not for everybody, and it's an overused, misused procedure, in my opinion. We're going to tackle that next Saturday. And there are many, many women out there that have been advised to do IUI thinking it's going to help them, but it often doesn't if they use it for the wrong indication. One of the reasons doctors do it all the time is because it's easy for any doctor to do. You don't need a lab, you don't need all of a high-tech stuff we need to do IVF. So they do that which doesn't work, but I hate to say it, is lucrative. And I think wrongly so. And next week we're going to delve into that. So please spread the word around. And we'll have a seminar, a webinar next Saturday at 2 p.m. Pacific time, 5 p.m. East Coast time, when we'll talk about that subject at length.
Perfect. We'll go back to answering some questions on endometriosis. Real quick, anybody who wants to see the last 2 live sessions that we've had with focused on endometriosis and then another one that focused on miscarriages, all of that is on Dr. Sher's YouTube, and you can find Dr. Sher on every platform at Dr. Jeffrey Sher on all platforms. So go check out his YouTube and support that channel as well. We're going to answer Ava04 on TikTok. They said, I had 7 failed transfers. I have high NK cells. I had endo surgery. So let me open it back up. How could I have adeno?
Wow. You are a textbook example of what I've been talking about all afternoon. You have natural killer cell activation, which is preventing the embryo attaching. You've got endometriosis that can affect the quality of the eggs you're producing. You're not going to get pregnant if you put a good seed into a bad soil. And since we know you've got an implantation problem linked to natural killer cell activation, which occurs in 1/3 of women with endometriosis, there's your answer. This is a solvable problem. We can get you a baby if we do the right things. I really think you may want to at least consider, just consider, going to the bio and clicking on that second option, which gets you a questionnaire that you fill in quickly, which gets to Patty Congress, my office manager, who will reach out to you and set you up to have a 1-hour online consultation with me. I think I can help you achieve your dream. I think what you've done is really quite sad, because if you've got activated natural killer cells with an immunologic issue, no matter what we do, the best embryos in the world from anywhere is not going to produce a viable pregnancy easily in you. This thin book, this thin one, is one of the 2 I give free. Go to option 1, click on that, order the book and the articles that I've sent you, and also option 2, if you want to, connect with me and talk to me one-on-one.
Alright, we're going to answer Dora the Explorer here. They said, I have endo and underactive thyroid. They have normal T4 but high TSH. Does this mean you shouldn't try to conceive?
If you've got a high TSH and an underactive thyroid, the likelihood, 75% likelihood, is that you've got Hashimoto's disease, an autoimmune hypothyroidism, which is the commonest cause of reduced thyroid hormone production and increased TSH in women. If you've got this autoimmune problem, you will have increased thyroid antibodies, TPO antibodies, and or antithyroglobulin antibodies. And if you do, there's a 50-50 chance you've got an immunologic implantation dysfunction. Back to this thin book again, with all of the issues relating to failure to conceive. If the uterus is not receptive to the embryo, we call it an immunologic implantation dysfunction, IID. Now, I don't want to come across as sounding haughty, but there are not many people in the field who fully understand or espouse to the immunologic issues that are so commonly the reason for women having inexplicably failed embryo transfers, miscarrying repeatedly, or failing to get pregnant when they've got certain types of problems that cause the immunologic activation. I think you may well be that person. Maybe you want to take the advice I gave the previous patient and go to option 2 on my bio, click on it, bring up the questionnaire, fill it in 4 minutes and get it off to Patty so she can link up with you and arrange perhaps for you and I to have a 1-hour online consultation where I can solve your problem. I told you an example earlier on of an Australian doctor who I treated at the age of 42 when she was almost premenopausal. And she'd had 24 failed IVFs with the exact problem you're describing. She has a baby, which is my godchild at this point.
Awesome. We're going to respond to Hayes. They said, I have complicated endo. Is IVF possible for me?
Absolutely, but it depends upon how complicated, what are the issues, and we would need to talk for me to help you with that.
Okay. User 34 said, what is... Oh, sorry, let me open it back up. Oh, and now I lost it. Sorry, 1 second, hold on. IVF. What is the success rate of endometriosis using IVF?
Once you get a good embryo, you put it into a uterus that is either receptive or has been rendered receptive through the proper treatment. The chance of having a baby should be the same as if that embryo had been put into a uterus that wasn't adversely affected and not impairing implantation. So it all depends upon getting to those points. And there we have to consider that women with advanced endometriosis are often older, meaning that their egg quality is reduced and have diminished ovarian reserve, so you get fewer eggs. So we may not be able to get to you getting good embryos. Most important in that, and I cannot overstress that, is utilizing the right protocol for ovarian stimulation. An individualized protocol. You can't use a one-size-fits-all recipe approach to deal with that problem. I urge you to take this into consideration. It's all about quantifying, identifying, and evaluating the variables that can affect your ovaries' function, the number and quality of your eggs, and age. Diminished ovarian reserve is another one, and we can do nothing about age and ovarian reserve, but we can sure as hell individualize the protocol and try to overcome the effects that occur in that situation that causes the ovary to overproduce that hormone testosterone that interferes with egg development. We can do that with the right protocol. So that's the first part of the question. The second part is that when we put the embryo in the uterus, we have to be darn sure that there are no anatomical or immunologic impediments to the attachment of the embryo. Just like you can't put a good seed in a bad soil, you can't put a good embryo that's PGTA normal into a uterus that is non-receptive. You'll get no take. So it's important to look at the factors that could play a role and then address them in advance and rectify those problems. If you do those things and you're successful in getting a normal embryo and you're successful in regulating the environment for implantation, the chance of pregnancy should be the same as if you never had the problem at all. That's why it's so important for me to emphasize again, you cannot take a recipe approach in these kinds of complex issues. You've got to individualize your approach depending upon the profile of the person that you're treating, the clinical profile. And then target those areas where there are aberrations and fix them.
All right, we're going to respond to, if I pronounce this wrong, I'm so sorry, Kalsa. They said, can you prevent endometriosis, and what are the most usual symptoms to look out for?
The most common symptoms are pain with your periods. And usually it's a typical type of pain. The pain starts as the bleeding begins. Doesn't start a few days before, as it often does for other causes of pain with your period, such as pelvic infection, but it starts when the bleeding begins and gets worse as the period progresses. Second, pain with intercourse on deep penetration just before the period. That's called deep dyspareunia. Third, painful ovulation, very often on the same side every time. That usually points towards the possibility also of an underlying chocolate cyst or endometrioma. And the other one is painful ovulation, usually always on the same side. So if you think of those causes and you have them, and with it you have infertility and difficulty getting pregnant where there's no other explanation, endometriosis is high on the cards. And then a receptiva test done in your doctor's office can give you the diagnosis.
All right, we're going to answer this one. This is a larger case here. It says, what if I have endometriosis, Hashimoto's, rheumatoid arthritis, and PCOS? How does this affect my fertility?
Rheumatoid arthritis, Hashimoto's disease, endometriosis are all associated with an immunologic implantation dysfunction where your uterine natural killer cells are activated. You need full comprehensive immunologic testing. If it's a 50-50 chance for women with Hashimoto's, a 35% chance for women with endometriosis, about a 40% chance for women with rheumatoid arthritis, what do you think the chances are that you don't have an immunologic implantation dysfunction? Absolutely, I'm pretty sure that's the main reason for your problem, and we can fix it if they're causing an autoimmune natural killer cell activation. This thin book, go to the bio. The first option, free access to the books and the articles. But in your case, no question of a doubt, you have got an implantation problem. The PCOS is a whole different story. There we've got to deal with an individualized approach towards stimulating you so we don't harm the eggs or put you at risk of developing severe ovarian hyperstimulation syndrome, OHSS. And that requires very careful and individualized approaches to ovarian stimulation. Reasons people come to me from all over the world for that problem. So in your case, we've got a seed issue, the egg quality because of your underlying PCOS, which we can address, and second, an implantation issue due likely to an immunologic cause, which we can quantify, identify, and typify and treat. And if we do that, you should be able to have a baby.
All right, responding to M here on TikTok, it says, is it possible to get naturally pregnant with a bilateral ovarian endometrioma?
Of course it's possible, but is it likely? No. And again, if you've got bilateral endometriomas, the bottom line for you is sclerotherapy today. You don't need surgery to do it. All you want to do is pick up your computer, send a text or an email to Patty Converse at concierge, concierge, at sherivf.com, and Patty will get in touch with you, put your name down, make a note when you send a letter to her, tell her you're interested in learning more about sclerotherapy. She will then put your name on our list, and if you then are ever interested, and you're never under pressure, but if you're interested, we can get you in and do sclerotherapy as an outpatient for you and get rid of the endometriomas without needing surgery or the potential to damage ovarian tissue through excising the endometrioma. Get in touch with Patty and she will put your name down, get back to you, and we'll be able to help you down the line. This is a big game changer. Spread the word around. If you've got such a problem, I have no doubt that you have many other friends with similar problems. Give them Patty's email address. Tell them to reach out to her. We can put her name down. And by the way, one of the articles that I'm sending you, when you go to option 1 on my bio, is an article that I wrote and only finished this morning on sclerotherapy. It was co-authored by my partner, Dr. Drew Tortoriello, and the director of our sclerotherapy program in New York, Dr. Sitara Ravikumar. So you'll see that article, read it up, and you'll understand what can be done and what's available. I think we're now at a point where we have to cut it off. Obviously, there are many, many of you here that can get an advantage from getting these books. They cost nothing. These 2 books, free of charge, along with 2 articles I wrote on endometriosis. One on sclerotherapy for endometriomas, and the other one on endometriosis and infertility, and a strategic approach towards treating it that is rational and that you should take up. You should know I am not all-knowing, and there are people out there that would have differences of opinion to me, and I respect those opinions. But after 40 years in this field, and I don't think anyone has been doing it longer than me, I've been able to entrench those things that work. And I basically want you to know that whatever I tell you, I would apply to my own daughter if she needed advice. So please read the books. Feel free to contact us anytime if you need my input personally, again through my bio, or get the books and read them. And please spread the word around for people that want to attend these webinars every Saturday. With the odd exception, it will be a midweek one, but we'll announce that when it comes. Every Saturday, 2 p.m. Pacific Coast time and 5 p.m. East Coast time. And join us for a 2-hour session like this. And follow us on social media. And we will be more than happy and delighted to give you the best advice we're possibly capable of doing. It's my job. I love what I do. You couldn't stop me doing it because I love doing what I do that much. That's the only reason I continue to do it at a time in my life when I really don't have to do it anymore. But I need to for my own need. As long as I can be of help, reach out. Thank you all so much for attending. Have a wonderful what's left of the weekend.
If you guys missed any of the live session today, please go find Dr. Sher at Dr. Jeffrey Sher on all platforms. You can find the full live stream on YouTube at his at Dr. Jeffrey Sher. And we hope to see you guys next week. Thank you all for being here.
Thank you.